Hello students, my name is Alok Semwal and in today's lecture I am going to talk about mode of action of antihypertensive agents. First category of antihypertensive agents include diuretics. Diuretics generally acts on kidneys to increase excretion of sodium and water. Thus they decrease in blood volume and causes decreased blood pressure. This is generally accomplished by altering how the kidneys handle sodium. If the kidney excrete more sodium, then water excretion will also increase. Most diuretics produce diuresis by inhibiting the reabsorption of sodium at different segments of the renal tubular system. Sometimes a combination of two diuretics is given because this can be significantly more effective than either compound alone. This happens because of synergistic effect. The reason for this is that one nephron segment can compensate for altered sodium reabsorption at another nephron segment. Therefore, blocking multiple nephron sites significantly enhances efficacy. We already studied mode of action of diuretics in the last chapter. So for detailed mode of action, check out my previous lecture on the topic mode of action of diuretics. Second category is of symptolytic drugs. Symptolytic drugs are further subdivided into several categories. These categories are centrally acting agents, beta-adrenergic blockers, alpha-adrenergic blockers, ganglionic blockers, and adrenergic neuronal blocking drugs. Symptolytic drugs can block the sympathetic adrenergic system at three different levels. First, peripheral symptolytic drugs such as alpha-adrenoceptor and beta-adrenoceptor antagonists block the influence of norepinephrine at the effector organ such as heart or blood vessels. Second, there are ganglionic blockers that block impulse transmission at the sympathetic ganglia. Third, there are drugs that block sympathetic activity within the brain. These are called centrally acting symptolytic drugs. Now, centrally acting symptolytics block sympathetic activity by binding to and activating alpha-2 adrenoceptors. This reduces sympathetic outflow to the heart, thereby decreasing cardiac output by decreasing heart rate and contractility. Reduced sympathetic output to the vasculature decreases sympathetic vascular tone, which causes vasodilation, and reduced systemic vascular resistance, which decreases arterial pressure. Final result is fall in blood pressure. Mode of action of beta-adrenergic blockers. The mechanism behind which beta blockers exert their effect is by the reduction of cardiac output through lowering of the heart rate. They bind to beta-adrenergic receptors and blocks the activity of normal ligand such as norepinephrine or epinephrine from binding to the beta-adrenoceptor by competing for the binding site. Beta blockers bind selectively to beta-adrenoceptors, acting as competitive antagonists. Predominant beta receptor type in number and function is beta-1. Beta-1 adrenergic receptors are located primarily in the heart and kidneys, and when stimulated cause cardiac muscle contraction as well as water and salt reabsorption. Beta-2 adrenergic receptors are located primarily in the bronchial musculature and vascular smooth muscle. When stimulated, beta-2 adrenergic receptors cause bronchial dilation and blood vessel contraction. Mode of action of alpha-adrenergic blockers. There are two types of alpha receptors, alpha-1 and alpha-2. Alpha-1 adrenergic antagonists cause vasodilation by blocking the binding of norepinephrine to the smooth muscle receptors. Non-selective alpha-1 and alpha-2 adrenoceptor antagonists block post-junctional alpha-1 and alpha-2 adrenoceptors, which causes vasodilation. Mode of action of ganglionic blockers. As the name suggests, they block impulse transmission at the sympathetic ganglia. However, ganglion blocking agents that selectively interfere with sympathetic transmission have not been developed. But the hypotensive activity of ganglion blocking drugs in general is predominantly a reflection of net decrease in cardiac output and total peripheral resistance consequent upon a reduction in sympathetic outflow. Ganglionic blockers are not used in the treatment of chronic hypertension in large part because of their side effects and because there are numerous more effective and safer antihypertensive drugs that can be used. They are, however, occasionally used for hypertensive emergencies. Mode of action of adrenergic neuronal blocking drugs. Reserpine is an adrenergic neuronal blocking drug. It inhibits granular uptake and storage of biogenic amines such as norepinephrine, dopamine, and serotonin from the cytoplasm into storage vesicles in the adrenergic nerve terminals in all body tissues. And this causes depletion of biogenic amines. So of course, the sympathetic function is impaired because of decreased release of norepinephrine. Reserpine has been used for the management of hypertension, but nowadays it has largely been replaced with newer agents with better side effect profiles and fewer drug interactions. Next category includes vasodilators. Mode of action of hydralazine. Hydralazine is a directly acting vasodilator. Molecules of hydralazine combine with receptors in the endothelium of arterioles, which results in nitric oxide release. Release of nitric oxide causes relaxation of vascular smooth muscle, and final result is fall in blood pressure. Minoxidil. Minoxidil is a powerful vasodilator. It has two major uses as an antihypertensive agent and also used in alopecia. Alopecia is a condition that causes hair to fall out in small patches. Minoxidil is a prodrug which is converted to an active metabolite which acts by hyperpolarization of smooth muscles and thereby relaxation of smooth muscle. Final result is hydralazine-like effects. Sodium nitroprusside. It is a nitrovasodilator that acts by releasing nitric oxide. Nitric oxide activates the enzyme guanyl cyclase, which in turn activates cyclic guanosine monophosphate protein kinase G pathway, leading to vasodilation. So it mimics the production of nitric oxide by vascular endothelial cells, which is impaired in many hypertensive patients. Next is mode of action of calcium channel blockers. There are three types of calcium channels in smooth muscles: voltage sensitive, receptor operated, and leak channels. Voltage sensitive are again three types: L type, T type, and N type. Normally, L type of channels admit calcium 2 positive and causes depolarization, which leads to excitation contraction coupling through phosphorylation of myosin light chain and contraction of vascular smooth muscle. Final result is elevation of BP. Calcium channel blockers generally block L-type channel and thus causes smooth muscle relaxation. Dihydropyridines have highest smooth muscle relaxation and vasodilator action, followed by verapamil and diltiazem. Dihydropyridines also have diuretic action. For detailed mode of action of calcium channel blockers, check out my previous lecture on topic vasodilators. Mode of action of ACE inhibitors. Our kidneys synthesize renin, which acts on a plasma globulin substrate to produce angiotensin first. This in turn is converted by a peptidyl dipeptidase to angiotensin second. Angiotensin second is a potent vasoconstrictor. Here you can see ACE inhibitors produce vasodilation by inhibiting the formation of angiotensin second. Angiotensin converting enzyme also breaks down bradykinin, which is a vasodilator substance. Therefore, ACE inhibitors, by blocking the breakdown of bradykinin, increases bradykinin levels, which can contribute to the vasodilator action of ACE inhibitors. The increase in bradykinin is also believed to be responsible for a troublesome side effect of ACE inhibitors, namely a dry cough. Mode of action of angiotensin antagonists. These are also known as AT1 antagonists. These drugs have very similar effects to angiotensin converting enzyme inhibitors and are used for the same indications such as hypertension, heart failure, and post-myocardial infarction. Their mechanism of action, however, is very different from ACE inhibitors. Angiotensin antagonists are receptor antagonists that block type 1 angiotensin II receptors on blood vessels and other tissues such as the heart. These receptors are coupled to GQ protein, an IP3 signal transduction pathway that stimulates vascular smooth muscle contraction. Here GQ protein and IP3, which is inositol triphosphate, is responsible for cardiac signal transduction mechanism. Because angiotensin antagonists do not inhibit angiotensin converting enzyme, they do not cause an increase in bradykinin, which contributes to the vasodilation produced by ACE inhibitors and also some of the side effects of ACE inhibitors such as cough and angioedema. Thank you.